Today's speaker is Deanna Emmons. Deanna is a registered dietitian who began working in oncology 11 years ago at Elkhart General Hospital in Elkhart, Indiana. She graduated from Bluffton University in Ohio with her bachelor's degree in dietetics. She completed her internship at IU Health Methodist Hospital in Indianapolis. In her current position, she provides nutrition counseling to outpatients receiving radiation therapy, oncology inpatients, and surgical inpatients. Utilizing a combination of nutrition education and hands-on assistance with enteral nutrition, she supports the nutrition needs of patients before, during, and after cancer treatment. In addition to her responsibilities as a dietitian, she enjoys spending time with her husband, watching TV, and performing saxophone. Today, Deanna is going to be sharing her quality improvement project involving feeding tubes. Though the project focused on people with head and neck cancer, it's still relevant to the ALS population. Our hope is that her presentation will encourage institutions to standardize their pre and post gastrostomy tube placement care. And again, we want to thank the Dietitians and Nutrition Support Dietetic Practice Group of the Academy of Nutrition and Dietetics for providing the research grant to support this presentation. And with that, I'll hand it over to Deanna.
Thank you, Stephanie, for inviting me to do this. I hope that all of you get a lot of information, valuable information from this, and that it's helpful for you. So I'm Deanna, and I'm from Elkhart General Hospital. It's in northern Indiana. It's about a half-hour east of South Bend. Like South Bend is Notre Dame. Most people know where University of Notre Dame is, so that's where I'm at. Just to give you a little background, our Elkhart County is a county known for the RV capital of the world. So there is a lot of factories here. So a lot of our patients that we deal with come from the factory environment. So, you know, the things that go along with it, the stressors and all of that is kind of our main clientele. So with that, I will just say I don't have any disclosures, although I apologize for any technical difficulties that I may have, but I'm going to do the best I can. I'm not the best with technology, so we'll just leave it at that. So all of you probably have a pretty good foundation in ALS and its management. I just had a couple of slides of some basic information to go through some common ground that we have between ALS and the patients that I had go through this quality improvement project, which are patients going through radiation treatments. So although they're two different entities, they have a lot of things that are very common between the two. So just as a basic background, ALS is a progressive disease, as I'm sure you all know, where the brain loses some connection with the muscles, and there's not necessarily a cure for it, but the main thing is palliation and the best quality of life that they can have. So of course, if their muscles are getting weaker, they're going to have some issues with swallowing, some issues with breathing, because all of those function from muscles. So if they go long enough without being able to eat well, of course, they can become malnourished. They have an increased risk of pneumonia and aspiration, and typically wouldn't get over it as fast if they're malnourished. So there's several different ways that G-tubes can be placed. And so one of them is through radiology, another one is through gastroenterology, and the last one would be surgically placed. But for obvious reasons, the first two choices are the best, usually because it doesn't require a major surgery. It's a pretty quick outpatient procedure. So with ALS, though, comes an added risk is their breathing. And so making sure that they are able to breathe during the procedure is a major thing. So there is this sort of calculation out there that I don't know who's aware of it, but I just thought I would bring it up, that to decide which way that you want it placed, if the forced vital capacity divided by what is predicted is greater than 50%, they're going to have less of a risk for respiratory compromise. And if it's less than that, sometimes doctors are not comfortable having a tube placed, because if it's placed by a gastroenterologist, you're going to have the big endoscope that goes down their throat. And obviously, if there's a tube going down their throat, it is going to impact how much air can come in and out, how they can breathe. Whereas in radiology, when a tube is placed, it's a very, very small tube that goes in there and it comes out very quick. It's simply to inflate the stomach so that it, for lack of better words, so that they blow up the stomach like a balloon, so that when they put a hole through there, it only goes through one side of the stomach and not both sides, because when the stomach is empty, it can kind of collapse on itself, and that would be easy to happen. So if they do not have good respiratory function at the time that they are going to have a tube placed, if they go to a hospital that has experienced physicians placing this and there's respiratory support there, they still could potentially have a tube placed, more than likely by radiology, and not necessarily have to be surgically placed. So adequate nutrition and hydration are crucial for just life in general, let alone weight maintenance. So the tube, kind of a rule of thumb that I have heard is if somebody has lost like 10% of their weight, that might be a good guideline to start with to decide when it's appropriate to get a tube placed. Some patients would, for obvious reasons, would like it earlier. They don't want to get that far into it. And other ones may wait till later because, like my patients, they may be in denial and they don't want a G-tube because my patients kind of sometimes feel like they failed if they get a G-tube, and that's not at all the case. And I think it's just working through the whole mental process of having a gastrostomy tube and getting them prepared ahead of time for that, even before the tube is actually scheduled to be placed, is just kind of getting that mental preparation. So it's easier for them to accept when the time comes for them to have it. In that, modifying the diet, having softer foods, even pureed foods, even using nutrition supplements, all along the way to help them maintain their swallow function as long as possible is really important. So whether or not the tube is placed by radiology, gastroenterology, or surgically placed, the bottom line is at some point in time, there's probably going to be a need for a gastrostomy tube if that is a goal that the patient has as far as their nutrition status goes. So I know they've kind of become a standard of care for treating weight loss and reducing the risk of malnutrition in ALS patients. So this slide just has a picture of a typical gastrostomy tube that's placed by radiology. They can place G-tubes, GJ tubes, which are G-tubes with an extension into the jejunum. They can also replace J-tubes, but they can't place a J-tube initially. At least our facility is not able to do that. If a patient needs a J-tube, that would be either surgically placed or by gastroenterology. And then gastroenterology also places G-tubes. And then surgery, if neither of those options are available for anatomy reasons, or maybe the respiratory issues, surgical placement is always an option. So I'm going to flip back and forth a little bit in the next few slides between outpatient and inpatient, and I hope it doesn't get confusing, but the hospital I work at is a community hospital. Our average census is probably 150 to 180 patients. So we don't have all the staff that might be at a tertiary care facility. So therefore we take on dual roles. So I actually cover outpatient radiation patients, but I also have a significant amount of inpatients that I cover as well. So when I flip between outpatient and inpatient, it ends up being the same person, but it really affects the whole process, the whole flow of how all of our work is set up amongst the dietitians. So hopefully that will not be too confusing. But anyway, To get started, just to give you background, so for our outpatient process for G-tube placement, the inpatient dietitian was covering it. So they would go do their assessment, do all the education, everything was done at the patient's bedside right after they had the tube placed. So the nurse did not have a part in it. Case management, nobody else really had a part in it except the where they went to have the tube placed, and then the dietitian takes it from there. And so when the patient went out the door to go home, they were just told to call their physician if they had issues. And so that is where we started having some problems, because a lot of them would end up in the emergency department because they really didn't know who they were supposed to call. Oh shoot, you know what? I just did something I shouldn't have done. My screen, I clicked on the wrong thing. Oh no. Let's see here. Let's see if I can get back. I'm looking for my little, oops. Well, that didn't do it. Again, I apologize. I am not the best when it comes to technology. So let's get back here. Okay. And then go down here. Okay, and we are back. Okay, sorry about that. Okay, so now as far as the inpatient process goes, it's pretty smooth. So the nurse goes over the tube site care, like around their tube, taking care of their skin. The dietitian goes over the formula, feedings and flushes. And the inpatient dietitian also writes the orders, obtains the physician's signature. And then from that point, the case manager takes it, sends everything off to the home medical agency, and coordinates a time for the home medical agency to come out to the patient's home when they're going to be discharged. So it's a smooth process on the inpatient side. Now, as far as the issues with the outpatient side, because G-tubes are not common, so we may have 15 in a year. On the outpatient side, it's not as common as on the inpatient side. So some of these nurses had not dealt with G-tubes in a long time. So they were not comfortable educating patients on it. Case management was not available. And so that's why it all ended up landing in the dietitian's lap, because nobody else knew what they needed to do. And it had to be done somehow. So most of our G-tubes are placed prophylactically for head and neck cancer patients. And the reason why is we want to get that tube in before they ever start treatment, so that it has a chance to heal before they start. The patients are not considered homebound. You know, for the most part, they're eating pretty well at this point. Most of them don't have any issues. They're just getting this tube placed so that it heals up before things start to happen from treatment. So they didn't qualify for home care nursing. So again, we couldn't have home care nursing help either with the education. And then the other big problem was, because we didn't know about these patients coming in for G-tubes, we weren't notified till the day of the procedure. And at that point, the outpatient dietitian, her schedule was already made out. The schedule for the radiation dietitian was already made out. They couldn't just open up their schedule that day. So that's why the inpatient dietitian got pulled in, because they had more flexibility. But of course, at the expense of seeing some of their inpatients, they were seeing now this outpatient. So there was a lot of issues here. In the radiation department, we were seeing skin infections, leakage. There was a red area around the G-tube site. They were having formula intolerance. The tube was getting dislodged or just getting not in correct position. Granulation tissue, and furthermore, everybody's getting frustrated because nobody knows what to do to prevent all these problems. And so over the last, I've been doing this for 11 years, and I can tell you when I first started, we probably only had 5 or 6 patients in a whole year that got G tubes. And it's just been in the last like 5 or 6 years that the head and neck diagnosis of cancer has just really increased. And to the point where, believe it or not, there was one year we had 30 new G tubes in going through the radiation department. It was crazy. But on average now it's running around 15 in a year. So about 1 or 2 new ones every month. So that was another reason that this really started to compound itself, was because we were getting more and more patients with G tubes. So of course, we're all getting frustrated. Everybody's getting frustrated. The nurse, dietitian, the physician, the patients were getting frustrated. A lot of people didn't know what to do. And furthermore, there were supplies not available. So our outpatient surgery department was not set up, like the recovery area, I should say, they were not set up for G tubes. So they didn't have syringes, they didn't have gauze, they didn't have all the stuff that we need to use to show a patient how to take care of their tube. Furthermore, we didn't have that in the radiation department either, because the tubes were so far and few between. So getting the supplies was quite an issue too. So there was a nurse in the outpatient surgery recovery area, one of the nurses in the radiation department, and then myself kind of got together. We're like, something needs to be done. This is crazy. We are having too many problems. This should not be this should not be what happens with our G tube patients. So we kind of put our heads together and decided there's got to be a better way. So we formed this team and started to brainstorm what we could do to help improve the process with what we had, because we knew that they're not going to add on any more staff. So we're going to have to make this work with what we have. Some of the barriers that we had with patients was, of course, they lacked the knowledge of how to take care of their tube and who to contact if they had issues. So our issue was, how do we get them more knowledge? How do we give them everything that they need? So the scheduling of the G tube, somebody's got to know this ahead of time. So we need to be notified before the day of. The timing of the patient education, there's got to be a better way than just right after their treatment or right after it's placed. The staff have to know more about how to take care of G tubes. We got to have the supplies. Who's ordering the home supplies and coordinating all of that? And then who is going to follow these patients? Who is going to see if what we did made a difference? So there is not a lot of information out there. When we first started working on this, most of the information about patient education is on pediatric patients, which, pediatric patients with G tubes is still similar to an adult. The main difference was, though, they were educating the parent, and we needed to educate the patient. So that's a little different, especially with adults too, you know how that is. So we had to come up kind of with a modified plan of what they did. So what they did that they found worked was, in this article, it was called the Evaluation of a Discharge Education Protocol for Pediatric Patients with Gastrostomy Tubes. So what they did was they came up with 5 education sessions. They had 2, now I'm kind of forgetting. I think it was 2 before they had the tube placed, and then there was 3 after the tube was placed. So we're like, we do not have the time or the staff to come up with 5 different times to do this. So we thought, we're going to try 3. We're going to try 1 at least a day or 2 before the tube is placed. The second one would be, again, we do it right after the tube is placed, and then somehow get a 3rd one in there some way after that. And we use 3 different media methods. They used 4. So the 3 that are the same was the verbal instruction, the written instruction, and then we came up with a little stomach mannequin that I'll show you. And the additional thing that they used was they made their own videos. We didn't have videos. So we thought, we'll try these 3 methods, see how this goes. So So that's what we did. As just an overview of the study, we found that 85% of our outpatient G-tubes were head and neck radiation patients. So therefore, that's why we chose that population, because they're the majority of the tubes placed at our hospital. Furthermore, they're coming in for treatment 5 days a week, Monday through Friday. They're here for their 10, 15-minute treatment. They're easily accessible. They have to meet with the doctor once a week. So it would be very easy for the dietitian to follow up with them every week. It was very easy to add on things for the nurse to be checking with the patient, because they're already seeing them once a week. So that's why we chose this patient population. And in our facility, radiology inserted G-tubes tend to be the best method. And the reason why is because with head and neck patients, if they have a tumor up here, sometimes depending on when it's diagnosed, I mean, it can be a good size and it can actually take up part of their esophagus. So if a gastroenterologist has taken a scope to go down to place a tube, that's going to take up space too. And we've actually had a couple patients that we referred to a gastroenterologist. They go to put the scope down and the tumor's too big. They can't fit the scope through. Okay, so now they got to cancel the procedure. Now we got to get them on the list in the queue to get it placed by radiology, which may, with any luck, it'd be a couple days later. A lot of times it was a week later. So now we're delaying treatment because we can't get this tube placed. So after that happened a couple of times, we just met with radiology, and it's just been a real smooth process for us to work just straight with them. We haven't had any issues with tubes being placed unless it was an anatomy issue, which it wouldn't have been able to be placed by gastroenterology either. And so there's very few times that happens, but when that happens, it was surgically placed. So in our pre-intervention group, we looked over 11 patients, and then in the intervention group, it was 16 patients. So we tracked the intervention group for 8 months. I would have loved to have been longer to get a little bit higher numbers there, but COVID hit and our outpatient department was shut down, the surgery part. So they were not placing any prophylactic G-tubes. It was only on patients that were admitted. And again, we had a process for that. The admitted patients weren't the problem, it was the outpatients. So we just ended the study at that point and just took what we had. So 94% of our patients were male. 69% were 60 years and older, and their BMI, 44% were over 30, 31% were at a healthy BMI, and the remainder were below that. That was just something we tracked. You can be malnourished at any range of the BMI. It was just something that we measured. And then 56% of these patients had tonsil cancer and were HPV positive, which was kind of an interesting thing. Typically, our patient population, the majority, it is likely from smoking and or alcohol. So it was kind of interesting that in this group that we happened to study, it was 56% were from HPV. 75% of our patients received chemo and radiation at the same time. And again, 94% of the tubes placed in radiation were by radiology, otherwise known as RIG, radiology placed tubes. So we collected data pre and post the intervention. The things that we had decided to track was any sort of reddened skin around their tube site, any sort of technique issues, GI intolerance, infection, or no issues at all. And then a treatment was additional education or review, or if they had to be started on antibiotics. So just to lay it out there in exclusion, we did not include surgically placed G-tubes simply because sometimes they were admitted as inpatients, sometimes they weren't. And it was so far and few between, it wasn't worth our time to track those. So this is what we did for our interventions. We increased the patient education sessions from 1 to 3, and we used 3 media methods. The nurse became a part of the teaching process and follow-up. The pre-procedure appointment was made for the dietitian so they could meet with them on a day separate from when their tube was placed initially. We created a G-tube booklet. We created a tube feeding order set, and that has really helped save time because we were handwriting orders. Then we included we found a home medical agency that actually helps with patient education. It is not considered home care. They don't bill for it, but they would come out to the patient's home to help them do their first feeding and bring a small set of supplies. And then we also provided the patient with a 3-day supply kit post-procedure just to take care of their tube site. It didn't include formula. It just was, I'll show you a picture of that later, but it was just to get them through until the home care agent or home medical agency can come by. Okay, I'm not sure if you can see this. It's a little bit small, but this is our scheduling process that it was changed. This is not how it worked to begin with. So you can see at the top here, no matter who is scheduling it, whether it's gastroenterology, primary care provider, or any other physician for that matter, or radiation oncology, no matter who is scheduling the G-tube, it all comes through here, okay? And then it goes to either this scheduling department here, or it goes to this surgery scheduling. So integrated scheduling is radiology, surgery scheduling is GI or surgery. So no matter which way, so we had to work with 2 totally different departments, getting the same process through 2 totally different departments. So when they were scheduled through integrated scheduling, what happened was the secretary in the radiation department, actually she scheduled the appointment with the dietitian first. And then once she had that set, then she'd send the order over to get it scheduled with radiology. So that then we were sure they would see the dietitian before their tube was placed. And we just asked that it's at least give us a couple days notice to schedule that ahead of time. And the further we went on, the more everyone got used to the process. And typically now, G-tube patients are scheduled like a week out. They meet with the dietitian maybe a week ahead of their procedure, which is so much better. And then on the other side, through surgery scheduling, they are to make a pre-admission appointment to meet with the nurse and the dietitian. Again, these are so far and few between. It really doesn't happen very often. And then they meet with the dietitian, and the nurse had a role at the start, but I will be honest, in the radiation department, because of so many add-ons and the schedule changing, it just got to be too much of a mess to try and pull nursing in. So they've really just kicked up their role when they see the patient every week. When they see the doctor and the nurse, they really do a good check with the skin and everything. So I do the initial education now with the skin site care, and the nurse picks it up from there throughout all of their treatments. And they're here for 6 to 7 weeks of treatment, so it's pretty significant. And then the nurse has their part if they're scheduled through surgery. So then after we do that, now we've got all our information. We can send it to the home medical agency, get the order written. So now we have just bought ourselves like a day or two for the home medical agency to review all of this, figure out what their coverage is, so that when they come back in a day or two, we can tell them, or the home medical agency calls them and lets them know how much their insurance is going to cover it or not. And if not, then we come up with a plan B. But at least they know that at the time they're here after their tube is placed, that they don't have to go home and wonder. Okay, so then after they get their tube placed, that's part of what we go through with them after their tube is placed when they're still here. And then I just do a quick review of like the formula, like their water flushes, just to remind them. And then the nurse does their part with the skin care and the site care, I should say, gives them the little sample bag and just answer any questions. I've actually had a couple patients come back between the time that I met with them first until post-procedure, that they have like highlighted the book I gave them. They have written out all these questions. It's great. I'd rather that happen than they go home and they have no idea what they're doing. And then the third session that happens is when the home medical agency goes out to their home to take like an initial 2-week supply of formula, gauze, tape, syringes, all of that. And they help them do their first feeding. Now, whether the patient actually continues that, we tell them they have to do a water flush in the morning, a water flush in the evening, twice a day, no matter what, if they're not doing formula yet. So, because again, a lot of my patients are still eating okay when they first start. This is a physician letter that we came up with. This was to inform all the physicians that were not a part of our core team to begin with. We had a couple on board when we initially started this process, so they knew what was going on. Believe it or not, I really thought we'd get some pushback from it because our physicians are just used to sending over orders, and within the next day or so, the tube is placed. And so we're like, no, the tube's not going to be placed until they meet with the dietitian. And they were okay with it. So I figured they must have seen the problems too. So they were actually fine. So this is just a letter that went out to all the other physicians that were not a part of the meetings, just so they knew when they send over orders, it may be delayed by a few days until they can meet with the dietitian. Okay, and then there was the standard role then for the nurse was they went over, and this was at the bedside, like right after they had the tube placed. They went over tube site care, pain control, and reviewed the water flushes. And so the pain, they can have a lot of pain through the first week after their tube is placed. And so just having a backup plan of like what they're going to do, they don't have to come to the emergency room. And since most of them are radiation patients, we just told them that if the over-the-counter pain medications did not work, just call the radiation department. And if it's over the weekend, there's an on-call physician. They can get something stronger ordered and have it sent to their pharmacy. And then what the dietitian did was review the diet post-op. There is, I know that technically you can use the G-tube like probably 4 or 5 hours after it's placed. Our radiology physicians prefer that they wait 24 hours. So they don't want them touching that tube for 24 hours. Their rationale is they would like to have it heal just a little bit before they start using it. So as a result, since they can't flush it or anything, they prefer that they follow a full liquid diet for the first 24 hours. As soon as they can flush it, then they can go back to eating whatever they were before. So we just have them, take supplements and stuff. So that's the post-op diet that I review with them. I review the logistics of home medical, like they're going to be in touch with them, your insurance is covering this, or you're going to have to pay 20%. And then just review the schedule of their water flushes and review again how to contact us if they have any problems. Because usually, I will say, usually there is a week or 2 lag time between the time they get their tube and when they start treatment. So they're not necessarily going to be seeing any of us in that time. So we just reinforce, please call. And that's where this booklet came in. It was actually the nurse's idea to have all of our contact information on the front because that was the big problem. They couldn't figure out who to call. So we put the radiation physician name up here with the phone number to the department, put the dietitian, which would be me, with my phone number, put the name of their product, and then the home care agency that we have had the best of luck with is Lincare, because they have someone come out to their home. Alex Home Medical is a great local home medical agency. It's just they don't provide anyone to come out to the house. They just ship them the formula and supplies. So generally speaking, that's why we use Lincare. The other thing to keep in mind about this book is we were having a lot of problems with confusion with patients because all the free books we got, like whether it was from, one of the Enteral nutrition suppliers or elsewhere, it had a lot of information that didn't necessarily apply. Like they may not be doing pump feedings. They may not have a J tube, you know, so we were crossing out all this stuff in the book. And then the pertinent stuff sometimes was in between the crossed out stuff and they'd miss it. Furthermore, these patients are overwhelmed and just kind of exasperated. I mean, most of them had just been diagnosed with cancer within the previous month. They are not only dealing with their cancer diagnosis, now they have to get typically chemo, they have to get a port placed, they have to get a G-tube placed. This is like a whole lifestyle change for them. And so condensing it down to only G-tube information, only bolus feeds is all that's in the book. And then there's a little bit of information about site care and what to expect like the first day or so, you know, when they with other things. So that would not necessarily be in a one of the enteral nutrition provider booklets. For example, like they put buttons in, you know, that those are going to fall off. Those help hold the skin to the stomach, and those are just replacing the tube. The sooner they fall off, the better it'll be. It'll kind of release some pressure. So little things like that are in there. And then if they have to start on a pump or start on gravity feeds, we give them the information at that time. We don't want to overwhelm them. But it does give them like signs and symptoms of intolerance, how to take care of their site, all of that stuff. This is our tube feeding order set. And I know this also might be a little bit hard to read. I'm more than happy if Stephanie, if you'd like me to send you a copy of this to send it out, that's fine. But this has just been like a lifesaver as far as it's a standard order set. A lot of the information at the top pulls in by itself, like the name, the diagnosis, their address. So I'm just filling out below the line, the height, weight, the tube feedings per G tube or J tube, the method of the tube feeding, the formula. Right here provides, that's where you put the calories and protein, water flushes, and if there's any additional fluid that they're supposed to get besides the water flushes, schedule of the feedings. Again, all of this stuff is required by insurance. So that's why I'm putting it in here. And by the way, the schedule is not something that has to be followed to the T. The insurance just wants to see that there's a schedule. Length of need. I always put 99 or indefinite because we really don't know, even though the majority of our patients get their tube out within about 6 months or so of when it's placed. Then there's syringes on here, gauze, the split 4x4s. This I will show you a picture of FlexiTrack device to help hold their tube. That is something that we have added on since this project that we really found helps. 1-inch paper tape rolls or Medipore tape, you know, if they need IV pole, bags, tubing, whatever, ambulatory pump. It's just kind of reminder, especially for if I ever have dietitians that cover and they don't always remember everything that orders, it's just kind of a prompt. It's a click. You can easily click these boxes in the electronic medical record that we use in radiation. Then the physician signs it electronically. And so that goes, I just print it out, send that along with my note, the physician's note, and insurance information to the home medical agency, and they take it from there. This was the lovely stomach mannequin that we came up with. I don't know if you can tell, but it's a Jif jar. My husband loves peanut butter, so we have lots of Jif jars at our house. And I thought too, you know, it's about the size of a stomach. This is probably a little bit larger than a stomach, but it's easy for them to see. My mom likes to sew. She was happy to try and make like a little fake skin sort of covering on it. So the front side of it here, you can see there's a hole. My husband drilled a hole in the bottle so that you can put the tube through. So we got an actual G tube for the dietitian and radiation, for outpatient surgery nurses, and for the radiation nurse. So there's an actual G tube for demonstration purposes, all 3 places. So if a patient had a question, everybody's got a tube they can show them. Okay, so then on the back, this was purposely not covered. I mean, the bottle's still there, but you can see right here the balloon. So I have a little syringe that I use that right here I put air in, and down here it's going to blow up this balloon, and that's what keeps the tube inside them and keeps it from pulling out. And then of course the disc on the outside is to help keep the tube from pushing in. So then they understand better how this is all working. Then, yeah, so then on the front, for them to take care of their tube site, basically it's warm soapy water, use Q-tips to help get under this disc, rinse and dry it off really well. Then we want them to use a barrier cream, just a light coating, and then put their gauze on and use the least amount of tape as possible so that this can dry out and heal. And then that keeps the tube from being pulled here. You can see a big old piece. On an actual person, they're going to have more area to work with than this Jif bottle, but they get the idea. Oh, and the reason we went with the Jif bottle is because when we looked at the stomach mannequins that you can order, they are very expensive. So I knew that probably wouldn't fly here at the hospital, so we came up with that alternate method. This is the 2 to 3 day supply kit that we give patients before they leave the hospital. So it's got 2 packs of split 4x4s, gauze. Each pack has 2. So there's 4 here. So there's 2 packs, a roll of paper tape. We do give them 1 little packet of Q-tips. Just as a reminder, you need to buy some Q-tips and have these on hand. Those do not come from the home medical agency. This is, our hospital just buys NutriShield brand barrier cream. Whatever barrier cream your hospital uses is fine. We just found that this helps protect the skin from, especially the first couple of weeks until it really heals around there. Some of those stomach acids are going to leak out, and our skin is not made to have stomach acid on it. So it gets all red and irritated. Sometimes it looks like it's an infection, but it's really not. It's just irritation. So this does not act like a lotion. Like, it doesn't sink in. It sets on top of the skin to help protect it. If the gastric juices leak out, it helps protect the skin so it's not irritated, so it doesn't turn red. And then the gauze, of course, is going to absorb those acids that come out, keep it from touching the skin. And then we give them 1 syringe because we expect them to do at least 2 water flushes a day to keep that tube open and working. So our results, you can see here, we had quite the results. No complications. So to start off, we had 9% of our patients with no complications. And then afterwards, we had 63% without complications. So it was quite a big difference. As far as infections go, we had a lot fewer infections. The GI intolerance, that went up a little bit. This was 3 patients. This was 1 patient. So again, it was a small number. So any change is going to look big. The main thing I can say with that is that it was a fluke. It was a total fluke that this GI intolerance was so low to begin with. The issues we had, we still have today. So I don't know how we did. It was 11 patients. So that's probably how we didn't have that problem. But anyway, the main issues that we have with GI intolerance is nausea, vomiting with bolus feeds. And we found the slower it goes in, the better they tolerate it. So when we slowed it down, like using the gravity bags, worked much better. The other thing is the further they get through radiation treatments, the more it slows down their GI tract. And so it's not uncommon at all for us to have to start patients on Reglan the last couple weeks of treatment to help their stomach empty faster so that they don't feel so full and they'll do all their feedings. Otherwise, if they feel full, they don't want to do all their feedings. So, but at least we're kind of, from doing this project, we at least figured out what the problems are, and we can figure them out a lot sooner and help prevent that weight loss and fix it. Technique issues. So with all the education up front, pretty much, we did not have any person with a technique issue in the intervention group, which was quite amazing. And then the Redden site, that went down. We still had a little bit of that, but not nearly as much as we did before. So, and that we found the barrier cream really helped with that a lot. So overall, we had a 54% reduction among outpatient G-tube complications. We created a multidisciplinary team. We had a protocol for each discipline, and then we used multi-format patient education sessions with adding in a total of 3 sessions. So you can see the blue is pre-intervention, all the complications. The post is intervention, much fewer, and with, yeah, the opposite right there too. So in conclusion, creating a multidisciplinary team we found can reduce patient complications. There's consistent information given to the patient now, no matter who gives them the booklet and goes over it, whether nursing or dietitian, they're all giving them the same information. Multiple education sessions, multiple learning methods. Before this project, all we did was just basically verbal, and then the booklet that we had that we were crossing out pages. So we had 2 methods. We didn't have a little mannequin to use. And then also incorporating that follow-up every single week during the radiation treatment really helped drive home what they need to do. So the timing and number of education sessions we found was crucial. I cannot tell you how much it helped to have a session with the patient before on a different day than when their tube is placed, just to get them away from it, get them thinking. Delineating who does what. Now everybody has ownership to it. They can't just say, I don't know. And the patient satisfaction has just gone up significantly. And I can tell you patients now like trust us. They come to us with questions. And even though we didn't measure it, I can tell you their anxiety level is much less. Like when I first meet with them, it's actually hard to get the assessment done because they are so wound up about this G-tube and what it looks like and what they do. But once we get through everything, it probably takes about an hour and a half, hour and 15 minutes to an hour and a half in their first session. But at least now they're touching the tube. They know what to expect. I'd rather it come out there. So in anyone setting this up at their facility, there's questions that have to be answered in order to figure out who's doing what. So things to think about: who does the initial patient family education? Is it only the dietitian? Is there a way you can separate that to the nurse and the dietitian both? Who is going to be responsible for writing and adjusting all the tube feeding orders? Who knows about insurance coverage? And maybe you just want to send it off to home medical to figure that out. That's okay. Who's going to send the orders to home medical? Who is going to continue to work on this if there's problems like formula issues, lack of insurance coverage? Who's going to follow up with home medical? If they called for their formula, it hasn't come. Now they're going to call you and try to figure out, where's my formula? Also, there is an ongoing, just like any prescription drug, the home medical agency is going to be sending an order over to the facility of the physician who signed the initial order to get ongoing recurring orders. So the patient, when they order a refill, they send a month's supply at a time, but they have to get that actual order renewed or whatever every 6 months to a year. So who's going to be signing that order? So for us, even though a radiation patient is discharged from us after 5 years of follow-up, our radiation physicians have said, hey, you know what? If it's a patient that is going to be a long-term G-tube patient, we will continue to sign their order, even though they're not following with us if nothing has changed. So that's been a big help. And then, insurance doesn't cover the dietitian appointment. Is your facility going to just provide it? That's what ours does. We don't charge for it. And maybe your facility does. So that's just something to consider. This form here, I just wanted to show you a quick peek of if somebody has Medicaid, this is the form that'll be sent over from the home medical agency. They typically fill it all out. The physician just needs to sign it and has to send it back. If they don't get it back, the patient will not get their next order. So it's a big deal. If they are not Medicaid, then the home medical agency usually has their own form, and it'll have similar information to this. It's like HCPCS codes, diagnosis codes, number of units of formula. It's things that home medical agency can do this. I don't want to put this on my order set. So that's why that is sent, it's for insurance. So they will have their form all filled out. It just takes the doctor's signature. Just know, as soon as that comes across the fax, the sooner the physician signs it and you get it back, the less likely there's a delay in their tube feeding orders. So if it's not covered by insurance, there's possibility of local resources. Maybe there's a navigator, a social worker at your facility that can help. I take patient donations, like when they get their tube out, if they have stuff left over, I take it so that I can give it to other patients that may need it. There's the Oli Foundation. I've also had patients just order it online from Amazon or from the manufacturer if they have the funds. So this is the FlexiTrack device that I had worked with the wound care nurse, and this was something, we were having a lot of problems still with tape, either a skin reaction to tape, or people were using way too much tape and the gauze couldn't breathe. It's like, what can we do to further refine holding up the G-tube without all the tape? So this is just a device. There's other ones out there that will stay on them for like 5 days to a week, and they can take a shower with it. And those two little blue tabs, you can see they come apart. Like if you had a Post-it note, they go together and then you pull them apart again, and the tube goes in between that. So that's why that's on the tube feeding order set, because Lincare will send up to 5 of those a month. So I have them do that. Then the other thing we found really helpful, again, to keep the tube in place so they don't have to use tape, is this Nelmed G-tube holder. There's other ones out there. Again, this is not the only one, but you can see it's like a belt, and the tube comes through the back here, and then you just kind of wind it around and then put this flap over the top. There's Velcro on both sides, and that will keep it firm to their stomach so it's not catching on their clothes or anything else. The big thing about this is you don't want to use it the first couple weeks after their tube is placed, because if they're leaking, I want them to use gauze. I don't want that getting all over this, because this would have to be washed in the washer. So all the information that we have used for tube feedings, the biggest resource I have used was Aspen. I have heard many webinars. I've actually gone to in-conference meetings about tube feedings, used Aspen, used our wound care nurse, used the inpatient nurses. And between all of that, we came up with kind of what has worked for us to reduce complications. So the big one is Aspen. The other one for dietitians, the Academy of Nutrition and Dietetics, the two practice groups, oncology and nutrition support, have a lot of information on tube feedings. So this is my reference list, and now it's open for questions. I hope some of this information will be helpful for you.